Hello everybody. Over the next hour or so we will discuss how to use the Siemens Prostate AI detection software in clinical practice. And what I'm going to do is to show you how it works in practice and what results you might be able to achieve. Here are my disclosures. Now we know that there are 4 benefits of the MRI pathway compared to the systematic biopsy pathway. 1, it reduces the number of patients undergoing a biopsy, and number 2, it reduces the diagnosis of indolent cancers, and this speaks to the negative predictive value or the rule out ability of MRI. But in some patients there is also an improved precision of risk stratification and an increased detection of clinically significant cancers, and this speaks to the rule in ability of MRI or its positive predictive value. However, there are still a number of challenges for the MRI pathway. 1 is that we still do a lot of biopsies and we diagnose no cancers or just indolent cancers. In other words, the positive predictive value is not as high as we would like. It's probably around about 50%. We also know that when we target biopsies we miss. And when we don't do biopsies, we miss. So we miss clinically significant cancers in both positive and negative cases. There's also quite a steep learning curve for radiologists, as many of you will know, and of course for the biopsy operators. And radiologists who work in sole practices without MDT feedback have poorer performance. And we know that there are marked variations between radiologists. And of course, it's time intensive to contour prostates and the lesions themselves, particularly if you're not getting paid for this type of work. So if you were to use AI to try to address some of these issues, what should the AI be able to do? Well, first of all, it should make sure that the benefits are delivered. And these benefits come from biopsy avoidance, as we said. So in other words, it should have a consistent and a high negative predictive value. Hopefully we can increase the positive predictive value, but importantly the consistency between readers should also be improved. Ideally, an AI system should be able to help us with PIRADS 3 cases when we look at patients and we're not sure what's going on, so maybe increase the specificity in those cases. It should improve our productivity by reducing the time required to do these contouring tasks, and the way we use the AI software should work with the way we work. In other words, it has to be stepwise, logical, understandable, and of course actionable. In other words, we need a sort of standard operating manual for this. Now the Siemens AI is able to meet a lot of these requirements, and essentially you need 4 steps. Number 1, you load the data, right? Activate the AI tool. You look at what finding it gives you, the segmentations that it outlines, and then if you accept them or you don't accept them, and then finally you have to output the contours for biopsy assistance or for radiotherapy planning, and of course you have to write your own report thereafter. So this is a brief demonstration, a brief movie that goes through the working of the AI software. Just listen to this and come back to me in about 5 minutes. Start off by typing in the patient ID, Siemens Prostate AI Demo 1 for example. Make sure that the assigned workflow is that of the prostate. Double click on the patient once the workflow has been assigned and the first window appears. On the top left you'll see the T2 image in the axial plane with the Adc map on the right hand side and then a fusion image in the middle. You'll see the coronal image automatically loaded. You can review the abnormality at this point, looking for extent of disease. There is the high B-value image, B1000, and that is the B2000 image, which we're going to window quite sharply. On the bottom right hand side we see a K-trans map or a wash-in map if you have a dynamic contrast enhanced study also available. So how do you reconstruct a B2000 image if it has not already been done at the scanner console? That's quite simple to do. Go to the Viewing tab. Here you can see the T2 image showing disease extending into the peripheral zone through the false capsule, confirmed on the coronal image. But for this purpose, just pick up the diffusion sequence, find an empty box, go to the bottom right hand side, Analysis Toolpack, ADC and B values, go to the computed B value image here, put in 2000. I prefer to do a scaling of 2 because that enables easier windowing, and press OK. When that's done, you'll find the images on the top right hand corner. Pick it up, put it anywhere you like, and you can sharply window these B2000 images. You can use the DCE task card if you want. Go to the middle of the gland and scroll through the data, and you can see that the lesion enhances quite briskly. Again, we window it. Put a mean curve if that is something that is in your practice. And the contralateral right transition zone also, and you can see that the curve shapes are very different. One has a wash in, one has a wash out, and the colors correspond. And then click on the AI, which is entitled Prostate Lesions, and you can see immediately that there is a heat map on the lesion. Its volume is 20 ml, as you can see. You can see that the software has allocated a score of 5 to this lesion with a level of suspicion of 99. Then you can assign the T2 score, the diffusion score, the DCE positivity, negativity, whether you thought there was or not extraprostatic extension. Identify this as the index lesion and then accept that lesion. Once you have done that, you can export the contours for biopsy. Again, you can see the outline of the gland, the outline of the transition zone, and the outline of the tumor are exported to a DICOM RT object so they can be used for biopsy purposes. Once you have done this, you can do the final review, confirm whether there is or there is not extraprostatic disease, look for pelvic sidewall lymph nodes, evaluate for seminal vesicle invasion in the coronal plane, load in the sagittal plane to confirm the absence of seminal vesicle invasion, and the last task will be to export the automated report to a PDF file. Locate the destination directory, type in the file name, and save. And you're all done. So you can see it's fairly simple to use the Siemens Prostate AI, which currently only uses T2 imaging and diffusion imaging in the axial plane. Welcome back. I hope that was clear. In this slide you can see the auto-generated report on the right hand side. You can see it's not very sophisticated. And on the left hand side you can see a PIRADS compliant report. So you can see the clinical details up on the top left. This man has low risk prostate cancer, is on active surveillance, and you can see we give the technique, the comparison. The report body consists of the prostate volume, calculated PSA density, appearances of the peripheral zone, the transition zone, and then your conclusion at the end. And the conclusion I reached was a large left anterior transition zone carcinoma with typical features of 3+3 cancer. The prior histological assessment underestimates the volume of disease. This is a clinically significant lesion and is not suitable for active surveillance. Because we practice in the UK, we give it a PIRADS and a Likert score in this particular instance, 5 for both. So now let's look at a few cases. We'll start off with a few large cancers, then a few small ones, and then discuss size limitations. I'll show you some false positive and false negative cases. I'll discuss the impacts of image quality and its use for PIRADS 3 cases, but we won't be discussing active surveillance. So here's a man with a large cancer. You can see this is a 71-year-old asymptomatic man presenting with a PSA of 10.1 and an abnormal DRE, and he was found to have a Gleason 4+5 cancer, both anteriorly in the gland but also at the base. So let's switch to the AI, double click on it, and let's see how quickly it comes up. You can see the software comes up pretty quickly. And you can see the first is a viewing tab. I'm going to double click the T2, window it. And if we look through this, we can see that there is this very large anterior carcinoma that seems to merge with another tumor here at the base. And clearly it's invading the seminal vesicles. And here we see a left internal iliac lymph node. So it seems to be two carcinomas. Let's look in the coronal plane. Double click again, window, go backwards. Here's the anterior carcinoma. Here's the basal lesion extending into the seminal vesicles. And the left internal iliac lymph node is over here. Let's look on the sagittal sequence, and we should be able to confirm those findings. Here's seminal vesicle invasion, large volume. Here is the tumor anteriorly, midglandular region, and apex from side to side. Okay, so let's just have a look at the AI's performance, and this is the prostate lesion detection button. Press that one and the AI will now switch on, and straight away you can see the T2 image here, the high B value image here, the Adc Map. This is the dynamic contrast series here, but we're interested in this image today. I'm going to double click on that. So there's the lesion 1. You can see it's 20 cc's. The glandular volume is 50.8 cc's. And if we go through this, you can see it segments the seminal vesicles, but not in its entirety. Notice how it does not segment the internal iliac lymph node here, and then it segments out the anterior lesion and the periphery of the prostate. At the bottom here you'll see it says lesion 1, so it's merged the anterior lesion and the basal lesion into a single abnormality, and it's given it a suspicion score of 89 out of 100, and the minimum ADC is 467 nanograms per ml. So it seems to have got this right. And what do we learn from this particular case? Well, the learning points are that if you have large lesions, they can become merged into a single segmentation. Number 2, you'll notice how the segmentation seems to be limited to the T2 outline. In other words, the extraprostatic extension in the region of the seminal vesicles, for example, did not occur, and the nodal disease was not done by the AI. And in fact, if you read the manual for this software, you'll see that the detection of the algorithm is limited to the prostate gland. If a lesion has extracapsular extension, the algorithm will detect mostly what is inside the prostate gland, and the algorithm will therefore not detect lesions in the seminal vesicles or the pelvic lymph nodes, and this is just in the performance characteristics of the algorithm. Let's look at the next case. This is a 57-year-old with a raised PSA, positive family history, and negative DRE, but we know has a cancer with Gleason 3 plus 4 cancers, and this is case number 23. So let's bring him up. Here he is, case number 23. I'm just going to go straight to the lesion. Here is the T2 image. We can see a large anterior fibromuscular stromal tumor, which has hyperintense signal on the high V-value image, and there seems to be some abnormality here in the left peripheral zone. Let's look on the ADC map. The ADC map is clearly very low, so this is a large anterior fibromuscular stromal tumor, and there seems to be a lesion here in the left peripheral zone. Let's look at that again on the T2. Can we see a lesion there? Yeah, so there seems to be something there in the left peripheral zone adjacent to the neurovascular bundle. Let's see how the algorithm is done. So here are the lesions. So you can see it's detected 2 lesions. So this is clearly the large lesion, which it's labeled as lesion 1. And you can see that the volume of the lesion is 4.4 cc's, and it's given it a suspicion score of 5. And lesion number 2 is this dumbbell-shaped lesion in the left peripheral zone at the apex. So it's found both lesions. So if we go back to lesion 1, you can see that's given a suspicion score of 93 with a minimum ADC of 632. The second lesion, which is at the left apex, it's given a suspicion score of 87. Okay, so what did we learn from this particular case? Again, the segmentation is limited to the T2 outline. The AI enables the segmentation of multiple discrete lesions when they are separate. Look at all the lesions that the AI presents to you and identify what is the index lesion. And remember, the index lesion is the lesion that you will go and biopsy, and it is also the dominant intraprostatic lesion for radiotherapy purposes. Okay, now let's look at some smaller lesions. Here's a small lesion in the right peripheral zone at the midgland in a 67-year-old man with lower urinary tract symptoms with a raised PSA, and we know that he has a Gleason 3 plus 3 cancer on a template biopsy. So he is case 21. Again, we're interested in the prostate lesion segmentation on this particular occasion, and I'm going to go straight for the segmented lesion, which is here. You can see that the lesion is highlighted in the right peripheral zone. It's quite a small lesion, 0.4 ml. It's been given a score of 3, so let's look at the suspicion score. The suspicion score is 78, and the minimum ADC is 846. So let's look at it on the T2 image. There it is. I mean, that's clearly a lesion in the peripheral zone adjacent to the prostatic capsule. And on the DWI, we windowed quite sharply. We can see that there is a focal area of hyperintensity on the high B-value image. We need to look at that as well in a second. And let's look at the ADC map. You can see the ADC map is low here in this area. And the ADC minimum was 841. But let's have a look at this lesion up here anteriorly. That looks suspicious. It's low on the ADC map. Let's look on the T2 image. It's right here. I think some of us would be suspicious that that was an additional lesion. But if we go to our map, we can see that that lesion is not picked up by the AI. So that's an interesting example. Is that a real lesion, do you think? It certainly looks real. I think I would call that. Might be worth looking at the dynamic contrast enhanced sequence. So I'm going to press on that tab, make sure that the DCE image is inside, and let's just work our way through that. Is there a focal area of enhancement in that area? Just a very subtle area. Perhaps something there, but it's contentious on the DCE sequence. So is there a size limit for the ability of the AI to be able to detect intraprostatic lesions? Why don't we look at that aspect next? Okay, well, here's a small lesion, again in a very similar position at the base of the prostate gland. This man has severe lower urinary tract symptoms due to BPH. His PSA is 7.3, and you can see this small focal lesion, which on an in-bore biopsy was shown to be a Gleason 4+5 tumor. And if we look at the AI, you can see that the AI fails to detect it. So here is the lesion in the peripheral zone. You can see it's within the prostate segmentation. There it is on the high B-value image. There's the Adc map. And it fails to pick it up. Well, maybe we should look at this case in more detail. So this is case number 13. So here he is. Let's have a look at the T2. You can see a large gland, and the lesion is right there, just at the edge of the prostate, a big median lobe, and there's the lesion, just there. Here it is on the ultra high B value image. There, slightly comma shaped. There it is on the ADC map. That's the prostate segmentation of the AI, and you can see there is no lesion shown. So there might be a size limitation to AI detection in the peripheral zone. I wonder if this is true in the transition zone. So here is a 57-year-old man with a raised PSA, 5.6. He's got a family history and he's a BRCA1 mutation. And you can see that I've identified two lesions. One is here on the left side of the midline, and another lesion is here on the right side of the midline. And let's see how successful the AI is at detecting these lesions. So before I show you the case live, let's just look at the summary images. He first presented in 2015 with a raised PSA, and he comes back 2 years later. The PSA is larger. We repeat the MRI. You can see the lesion is slightly larger. At this point, he has a mapping biopsy, and you can see this is diagnosed as a Gleason 3+3 cancer. He then goes on to active surveillance, but on active surveillance a couple of years later, you can see that the PSA has gone up, and the lesion appears to be larger, so this was rebiopsied, and this is now a Gleason 3+4 cancer on a template biopsy. So he's had two template biopsies, initial one, 2017, 3+3, second one, 3+4 disease. And if you look at the scans in 2015, there is no lesion in this area on the AI. In 2017, again, the AI does not seem to show a lesion, but in 2019, you do see a lesion, and here it is. So let's go and have a look at him. And here he is in 2015, Let's look at the AI segmentation. You can see the glandular volume is 60 cc's. Nice high signal peripheral zone, slight hypertrophy of the transition zone, and the lesion in question is here. Quite difficult to see on the T2 image. Here is the central zone, but no lesions seen at the site of the diffusion abnormality, and here is the diffusion lesion. There it is. There it is on the Adc map. I think that's very convincing. So that we know is a 3+3 lesion, and the AI clearly does not see it in 2015. Let's see if it sees it in 2017. This is 2017, as you can see here. And as you go through it, again, we don't see very much on the T2. It's somewhere in here. Here is the central zone. Difficult to see on the T2, but it's much more clear on the high B-value image. That's the B2000 image. There's the ADC map. So in 2017, there's a slight increase in size, but the AI does not see it. Let's look at 2019, and of course in 2019, you can see the date here. The AI clearly finds it, calls it a score 3. That means it has a suspicion score of 76 out of 100. The minimum PSA is 705. There is the lesion on the diffusion sequence. That's the ADC value. So the lesion is definitely larger now. Do we see it on the T2? I think we do see it on the T2 now. There it is on the T2. So there does seem to be some sort of size limitation that we should be aware of. It turns out that new algorithms are being developed, and if you apply these new algorithms, you can see that in 2015 the new algorithm does see the lesion. The new algorithm also spots it in 2019. So what did we learn from these cases? Well, small lesions at the prostatic base adjacent to the capsule may not be seen, so this means that we need to be particularly careful in these areas. The AI does see small lesions, but there may be a size limitation, particularly with the older algorithms. Algorithms are improving, and the sensitivity for smaller lesions is therefore expected to improve as we go forward. So we need to be careful about small lesions at the base, because these can lead to false negative results. And you can see that false negative results result in delays of diagnosis and of treatment. And here is another example. So this man has Gleason 3+3 cancer and is on active surveillance. And you can see over time that his PSA begins to rise. So in 2018 it's 4.6, in 2019 it's 10.5, and in 2021 it's 11.2, at which point he has a prostatectomy and we find a Gleason 3+4 cancer. So in 2018 we see this lesion here not detected by the AI because the lesion is outside the area of segmentation. And remember, we said the AI will only see things within the area of segmentation. If we look in 2019, we find the same problem. Remember, the PSA has gone up, the lesion is here. Again, it's just at the margin of the prostate gland segmentation. And in 2021, the lesion is larger. Look at the ADC, it's quite low. And again, we see that the AI misses that lesion but spots a number of other lesions. So let's look at the case in 2021, and this is patient AI28. So here he is in 2021. Let's have a look at the segmentation first. We go down. The lesion in question is in fact in this corner here, and you can see it's just at the margin of the segmentation. We're going to ignore these other lesions for the moment, but you can see that that lesion is not spotted, but it's very much present on the ultra high B value image. It's present on the Adc Map, and if we look at the dynamic contrast enhanced series, you can see that there's a focal area of enhancement in this area. And we now know that this was a Gleason 3+4 cancer. The AI does discover other lesions, such as this area here, which it scores as 3. Another area here, again it scores as 3. And the last area here, again that it scores as 3. Now these lesions were not identified on the prior scans, so what are these other lesions? Now on morphological images it's not really changed over the last couple of years, but the AI is clearly pointing to something there with a suspicion score of lesion 1 being 63, lesion 2 being 67, and lesion 3 being 62. So these lesions may well be false positive lesions, but in somebody with a rising PSA, when an AI spots something, then we need to be quite suspicious of these new findings. So how do you approach a man like this who has a definitive enlarging lesion on an MRI scan and a few equivocal lesions in the setting of active surveillance with a rising PSA? These types of changes are seen in about 1/3 of men undergoing active monitoring using MRI in men with active surveillance, but only half of these men, you can see, will turn out to have histological upgrading on a biopsy. So you can't really rely on MRI progression alone to prompt for a biopsy or definitive therapy. You need to look at other factors such as PSA density, PSA kinetics, and if they are all concordant, then obviously you need to use that information to re-biopsy the patient before definitive therapy. Let's look at some other false negative examples. So here's a man who has Gleason 9 disease in left-sided cores before he undergoes androgen deprivation therapy, and in this case you can see that the AI clearly spots the lesion in the left peripheral zone of the apex. But notice what happens after 3 months of androgen deprivation. On the T2 we can definitely see a lesion, but the AI on this instance does not see it because the ADC value has gone up and the high B value signal intensity has gone down. So drugs are important when we are trying to evaluate the prostate for lesions, and other causes for false negatives are poor signal to noise situation. So this man has a PSA of 5.6. He's had targeted biopsies through that lesion in the left side of the central zone, which showed a Gleason 4+5 cancer, and let me show you that the biopsy was done at that location. So let's take a look at him in a little more detail. Scan number 29. So here is scan number 29. Let's double click. Here come the images. We're interested in this image. Let's look at the T2 sequence. On the T2 it's really quite difficult to find the lesion, but the lesion in question is in this area here. We just see the normal central zone. On the high B value image It's not very good quality, as you can see. Let's try windowing it. We window it very sharply. We can just about make out some asymmetry in the signal in this area. Here is the ADC map. I think that would have been easy to miss, both for a human and for an AI. But it was spotted, as I've already said, by the radiologist in question. I guess he was looking at the dynamic contrast enhanced sequence, which is here, which showed asymmetric enhancement, and that probably alerted him to an abnormality in this area. And as I've already said, this turned out to be a Gleason 4+5 cancer on an indoor biopsy. So poor signal-to-noise situations will lead to false negative cases. This is also another situation where the AI didn't miss the lesions in a low SNR situation. So you can see this man's had two prostate scans, 2016 and 2018. In 2016, slightly older scanner, this was called a PIRADS2 lesion, and in 2018 he had a 3T scanner, and this time we called it a PIRADS5 lesion, and histologically this lesion here in the right side was a 3+4, and the lesion here was a 3+3. Let's look at the first scan. So these are the scans in 2016. Let's look at the T2. The lesions in question are over here on the T2 sequence. Let's look at the high B-value image. You can see this has a low signal-to-noise ratio, but we do see two lesions. They were not called, obviously, prospectively. Here they are on the ADC map. Quite difficult, I think. They seem to be high signal on the high B-value image as the central zone, so I can see why they were missed, but the AI clearly sees them both. So there's the lesion on the right-hand side, which is scored as a 4, and there's the lesion on the left, which the AI has scored as a 3. Let's look at the level of suspicion. The lesion on the right-hand side was scored as a suspicion score of 81 out of 100. The lesion on the left-hand side was scored as 75 out of 100. It would be interesting to look at the dynamic contrast enhancements since we have them, and you can see that both lesions are enhancing. So that should not have got missed, but it did get missed prospectively by a radiologist who participates in an MDT, but the AI clearly would have helped them if they had had it available. And in 2018 the AI clearly sees both lesions, but these are higher signal-to-noise ratio images. Other causes of false negative results are due to gas, rectal gas, and here's an example. So this man has a lesion here in the left peripheral zone, quite difficult to see on the high B-value image, a little decrease in the ADC value, but in this particular instance you can see the contrast enhancement clearly points to a lesion there, and that is the main role of DCE, particularly in situations where you have a lot of rectal gas. Here's another patient who has a lot of rectal gas, as you can see, causing quite a lot of distortion, but in this particular instance you can see this lesion is high signal on the high B-value images, low on the ADC map. There is contrast enhancement, and of course the AI sees it on this occasion without any problems. So the learning points are: false negatives cause delays in diagnosis and therapy starts. False negatives are caused by the presence of small lesions, as we've already seen, lesions adjacent to segmentation to the prostate outline or just outside because of geometric distortions or poor signal-to-noise ratio images. DCE can be helpful in reducing false negative results, particularly in low SNR situations or when there are distortions due to hip joint prostheses and rectal gas. But most importantly, you need to remember that AI algorithms have an operating point that is supposed to be like human expert readers. Just as humans make mistakes, and I've shown you a couple of humans that made mistakes, so we can expect the AI to have both false negative as well as false positive results. That's a perfect segue for the next section, which is on false positive lesions. Now, false positive lesions, top right on this graphic, undergo unnecessary biopsies. They are exposed to the risk of overdiagnosis, and if there is an overdiagnosis, then long-term active surveillance and the costs associated with that. The classical false positive is caused by infection, and here's a 62-year-old man with a persistent elevated PSA following a UTI. You can see his PSA is 9 nanograms per ml, but he had an abnormal DRE, and we know this patient had a granulomatous prostatitis on a biopsy of that lesion. So let's look at his scans and see what that looks like. So here is patient 8, just loading up now. Prostate lesions. Let's look at the T2 image first, which we can see here. And you can see a dark signal mass in the left peripheral and transition zones at the apex of the gland. Otherwise we see normal BPH, and the right side of the gland certainly appears normal. Let's have a look at the diffusion image. Here is the high B-value image, and we can see high signal intensity and low on the Adc Map, as you might imagine. And on the AI also sees the lesion. So this is a false positive lesion, as we already know, and the AI sees a false positive lesion. Okay, the suspicion score is 96, and the minimum ADC is 685. And in ordinary circumstances, you would say this was a T25, a DWI5. Before we decide on the DCE score, we should load the DCE into the lower right-hand window. There it is. There's the DCE scan, and let's walk through it. And there is general diffuse enhancement of this lesion. You might wonder about whether that's an area of non-enhancement. That should alert us to the fact that this is infection. And you can see that there is an area of non-enhancement suggesting that's an abscess. That went on to a biopsy, and that was, in fact, granulomatous prostatitis. Stromal nodules can also be false positive lesions, and here's an example. So this is a 68-year-old man with LUTS. He has a raised PSA 14, so he should have a prostate cancer, and indeed he looks like he does here in the left peripheral zone. 3+4 on a targeted biopsy. So let's have a look at this man. So the data is now loading. Let's go to prostate lesions, and let's have a look at this guy carefully. Double click on the T2 sequence. We can see straight away that there's a stromal nodule here with glandular tissue all the way around, and this looks like the cancer in question in the left peripheral zone medially. Now we should confirm that this is a stromal nodule by looking in another plane. So here I'm going to go to the viewing tab, put in the coronal image, and look at that a bit more carefully. It's got a big nodule of BPH. Here is the nodule, and that looks like a classical stromal nodule in the left peripheral zone. And let's now look at the AI. Go back to prostate lesions, double click here, and you can see that the AI spots that as an abnormality. So lesion 1 is this lesion here, score of 4, and I think all of us would agree there. But this stromal nodule, it's identified as a score of 3. So let's go back to lesion 1, and you can see the suspicion score is 86. Lesion 2, the suspicion score is lower, 71. And let's have a look at the dynamic contrast enhancement. Double click and go through that. And we see that the lesion enhances, but there's nothing worrying about the lesion in the transition zone. So this is a false positive on the AI, just a stromal nodule with a true positive, which is this carcinoma in the left peripheral zone. So here's another example of a stromal nodule, this time again in the left transition zone. But not all stromal nodules will come as false positives, and here's an example of a man who has a stromal nodule, but this lesion is not highlighted by the AI. But you can see the AI is highlighting another lesion and scoring that as a 4. And what is that lesion? And in fact, it turns out to be this lesion here. So what is this lesion? Is that another stromal nodule? Let's have a look at that more carefully. We need to go to case 11. So here is case 11. Double click. Load the data. The data are now loaded. Let's go to prostate lesions. And let's look at this lesion more carefully. So if we were to look at the AI alone, you'll see this stromal nodule does not highlight, but there is a lesion here. And be very careful of just accepting that lesion as an abnormality. Make sure you look at everything else that goes with that. So we need to look at the DWI, we need to look at the DCE, and we need to look at the Adc Map. And when you do that, what you notice is there's a big artifact in this area. So that's the high p-value image. There's the Adc Map, and indeed this is just an air artifact causing a false positive lesion in the prostate gland. Now, the air doesn't seem to be coming from the rectum. Where is it coming from? Well, we need to look at the air both above and below this lesion, and again we go to the viewing tab, and in the viewing tab, if you put on the sagittal image, you can see that there are air pockets both above and below the prostate gland in this area, and these are the sources of artifacts that cause the false positive lesion to appear at the base of the prostate gland. Here's that stromal nodule that we showed before that was not highlighted by the AI. In this case, the false positive lesion is caused by air artifact from bowel loops both above and below this lesion. So, important lesson there. Always corroborate any finding on AI with T2 and diffusion sequences, and of course you can always look at the dynamic contrast enhancement. So here are the DCE images, and these are the dynamic contrast enhanced sequences, and you can see there is no focal area of abnormal enhancement in this area. So this is a false positive due to the presence of artifacts, in this case above and below that prostate gland in that region. So, important lesson. Another question we need to ask is the central zone a common cause of false positivity? It doesn't seem to be the case. I've shown you several examples where the central zone doesn't come out as a false positive lesion, even when it is hyperintense on the high B-value image and low on the ADC map. So it looks like the algorithm has already compensated for this effect. So what are the learning points regarding AI and false positive lesions? False positives result in unnecessary biopsies and therefore expose patients to the risk of overdiagnosis. False positive lesions include infection, stromal nodules, and false lesions resulting from artifacts, but occasionally you might get some central zone lesions that are called false positives. Again, we have to remember that AI algorithms have an operating point which is comparable to human operators, so we should expect both false positive as well as false negative results when we use the AI. Lastly, let's just talk about indeterminate or PIRADS 3 cases. This can be surprisingly common in clinical practice. So if you look at the Mri study, which looked at 10 centres in the UK with mixed outpatient populations, what we find is that 1 in 4 men had a PIRADS 3 abnormality called, and 1 in 4 men had a clinically significant cancer. So these rates are higher than you would find just looking at the literature. So what should we do about these men? We can get a radiological second opinion. We can get AI to give you a second opinion. We can use PSA density. We can take them to an MDT, or we can just assume that they're all positive and biopsy them all. So let's see how an AI does with a PIRADS 3 abnormality. So here's a man who has a slightly raised PSA. The PSA density is just over 0.1, and the radiologist reports this as no focal lesion being found. And you can see that there is bilateral low signal change in the peripheral zone. There's no hyperintensity that we can see on the ultra-high B-value image, and you can see the ADC map and the dynamic contrast enhancement just shows diffuse changes. So I guess we can agree with this, but the AI is certainly showing us something abnormal. Well, 2 years later, you can see that the PSA has really shot up now. The DRE is positive, the PSA density is right up there now, and in fact he was biopsied bilaterally, and we found Gleason 3+4 cancers on both sites. So what was the AI seeing in 2019 that revealed itself in 2020? So let's have a look at case number 14 on both occasions, 2019 and 2021. So this is the examination in 2019. Let's look at the T2 to start with. Again, we see the diffuse low signal change in the peripheral zone bilaterally. Let's look at the ultra-high B-value image. Difficult to say that there are focal areas of abnormal signal in the peripheral zone bilaterally corresponding to the T2 sequence. The ADC values, those are low, but with no corresponding high signal on the high B-value images, so that is a PIRADS 3 abnormality. Let's look at the contrast enhancement because we are told that that would be useful. And let's scroll through that. And all we see is diffuse change. It is early but diffuse and non-focal. Okay, let's look at the AI then. And you can see that the AI in 2019 is certainly picking up a couple of lesions. So the lesion here on the left is being scored as a 5, and the lesion on the right hand side is being scored as a 4. So if we go to the lesion that's being picked up as a 5, it's given it a suspicion score of 93 with a minimum ADC of 706, and the lesion on the right hand side has a level of suspicion of 90 with a minimum ADC of 731. So it is certainly seeing something that we are not seeing. What about on the follow-up? Well, on the follow-up study, this is now in 2021, you'll remember. The T2 image again shows that diffuse low signal change in the peripheral zone bilaterally, somewhat similar to 2019. But on this occasion, you can see it's quite high on the ultra-high B-value image. And the ADC is again low on both sides. Let's look at the contrast enhanced study. Here's the contrast enhanced study. Just step through that. Again, we've got this rather diffuse change, non-focal, but early. And the AI shows us a single lesion, not bilateral lesions, which is what we would have expected, with a suspicion score of 5. But clearly on the ultra-high B-value image, both the left and the right peripheral zones are abnormal, and we now know that there was cancer on both sides. So what's going on here? I suspect this is due to the slightly older algorithm, and if you look at the latest algorithm, we can see that in the study for 2021, there are abnormalities detected and depicted in both sides of the peripheral zone. Let's have a look at another patient with a PIRADS 3 abnormality. This man had 4+4 disease in 2 cores on the left-hand side, and this is case number 17. So let's fire that one up. Here come the images. Prostate lesions. Let's start off by looking at the T2 sequence. Here it is. We can see an asymmetric wedge-shaped opacity in the left peripheral zone of the prostate gland, midglandular region, and at the base. This is the ultra-high B-value image. There seems to be a focal area of signal change here in the left peripheral zone on the ultra-high B-value image, and there is a focal area of low signal change on the Adc map. So I think we should probably call that a PIRADS 4. We should really confirm that with a dynamic contrast enhanced series. So let's look at that next and see if there is focal enhancement in that area, and there is. So this should really have been called a PIRADS 4 case, not a PIRADS 3 case. Okay, lesson learned. Let's look at the AI. And the AI, of course, calls it an abnormality, but only scores it 3. Interestingly enough, a score of 3 and a suspicion score of 73%. So it is not very sure whether this is or is not prostate cancer. And in fact, as I said, 2 cores from this area turned out to be Gleason 4+4. So you can see the AI was helpful for targeting, although it's put the suspicion score slightly lower than we would have expected. I think we should make that the last case that we review. We've learnt a number of important lessons during this tutorial. Clinical history is important, PSA, DRE findings, family history, infections, drugs are all important. The quality of the images is obviously key. Signal to noise ratio and rectal gas. Check the outlines of the segmentation, because remember the lesions may lie outside these segmentations, in which case the AI will not find it. And I've shown you a few examples where at the base of the gland, that's where the trouble seems to be. Review the ROIs that the AI presents to you, because these are likely to be true positive cases. If you have heat maps available for your own AI systems, look at those, but remember they are likely to be false positives. Remember, common causes of false positives are stromal nodules, the central zone which may be asymmetric, but also artifacts may cause false positives. False negatives are smaller lesions, subcapsular lesions, lesions that lie outside the segmented gland. So important to remember. Remember that the software is using biparametric MRI to make these determinations, but if you've got the dynamic contrast enhancement, you should use that and then assign the PIRAD scores. Clearly, if you're going to call a lesion which could be a false positive, you need to take into account the PSA density, the family history, and other risk factors. And remember finally to export the DICOM RT objects for fusion biopsies and for radiotherapy planning. So what sort of performance would you expect if you use this software in your clinical practice? You can expect a higher accuracy for lesion detection, particularly if you're using a PIRADS 4 cutoff and above, and you can expect about a 4% improvement in your performance. If you use 3 and above, then you will have a performance improvement of about 3%. Remember, there's a greater consistency between readers, which is important, and there'll be about a 20% reduction of reading times, but even a greater reduction in outlining tasks, which obviously take the most amount of time. Digging into this in more detail, we can see the false negatives are going down, which is good to see, but at the expense of a few more false positives for some radiologists. However, you have to remember that false positives and false negatives are not weighted equivalently. Missing a cancer is clearly more important than doing a biopsy that a patient doesn't need. So they can't be equivalent, but this is a fine balance, obviously. So the take-home points are that a modern AI-based prostate cancer detection software should be able to deliver a performance of having several radiologists with similar levels of false positive and false negative results. I don't think we can assume generalizability to other situations. If we're going to have a generalized decision support tool, then we will need more data using multi-center data, multi-vendor data, where studies take into account the clinical needs of patients, clinical settings, the disease prevalences, and patient preferences. However, we can all agree that AI assistance will be essential if we are going to successfully deploy a community-wide MRI-driven prostate cancer diagnosis pathway, both in the symptomatic patients and in the future for screen-detected lesions. Thank you very much for listening. I hope you found some of these tips and tricks useful for your practice.